Hello and welcome to ThePrint. For the first time, a dual chamber leadless pacemaker has been implanted in a child, specifically a 13-year-old patient at the UC Davis Medical Center. And today I'm joined by Dr. Daniel Cortez, who has set this world record. He's the director of Pediatric Electrophysiology at UC Davis. Welcome to the show, sir.
Thank you so
Uh,
much for having me.
Great to have you here, sir. So I think I would start with if you could just walk us through the case of this 13-year-old patient and the factors that led you to decide that led you to proceed with this procedure basically, and what made it crucial to perform the surgery on this patient basically.
Sure, of course. So this patient, as other patients who we have had, and as you see in pediatrics, have something called heart block. So the heart is like a house. There's plumbing and there's electricity. So it's not a plumbing issue as you think of most congenital heart disease with holes in the heart or things like that. This is actually an electrical disturbance. So the wires in the heart don't connect from the top to the bottom. And so over time, the heart rate gets slow because there's no connection to the brain, which connects to the top part of the heart. So basically, because of that disconnect, the patient started having dizzy spells, feeling like she was going to pass out while just sitting there, really had no good activity level. And we knew that this would happen over time, but it was sort of a matter of when in these patients that have what's called congenital heart block. So this heart block proceeded. She was feeling symptomatic, and then we had a discussion with the family since we've been doing leadless pacemakers now for a few years, but not this type of if this was one of how much activity level she wanted to have, kind of what would be the safest thing, and allow her to still be a kid. Prior to this, pacemakers for one chamber of the heart, so the ventricle or the atrium, we've been able to do that in children, but not. But this is the first case where we had it combined, and so discussed with the family. They were eager to move forward with this, given that it was we had sort of proven safety from the other types of pacemakers, and this would allow the patient to have be able to still be active and be as though she had no pacemaker whatsoever. So then we ended up implanting it and did it through the neck vein, actually. So just through one vein, put an IV in there. Patient came in that day, left the next day, and just with one single stitch that we take out the next morning, she was able to have a dual chamber pacemaker that could talk between the top and the bottom chambers of the heart, and she's continuing to do well with that. We'll program it sort of as she needs, as she moves forward and develops more heart block or more need for pacing. But so far, a few months out, she's doing really, really well.
So, how does this dual chamber leadless pacemaker differ from the traditional pacemakers? I mean, in terms of the functionality and the benefits, especially for the pediatric patients. Basically, since you talked about this congenital heart block, it doesn't happen in children very often. Like it's 1 in 1 lakh cases, right? So, how is it like? How does this work in terms of the benefit, especially for the pediatric patients?
Great question. So most pacemakers we think of, at least for adults, have a little box that connects to two wires that go in through the vein into the heart. That box is sort of the weak point of the pacemaker. So kids that like to move a lot, move their arms up and down a lot, play sports, get hit in sports, things like that, those pacemakers are very weak and can break very easily, whether it's within a few months or a few years. So just really, kids that want to be active, regular pacemakers aren't great. The other option we have for kids up until this point was surgically placed pacemakers, where they cut open the chest and have to surgically put them on the atrium and the ventricle. So much more aggressive. Takes several weeks to heal from that. They're in the hospital for several days, and those kind of pacemakers also are very weak in terms of activity level that kids can have. They could fall and break them. They could jump on a trampoline and break them. So leadless pacemakers are basically like two vitamins. If you think of two vitamins or that go into the heart. One little capsule goes in the bottom chamber of the heart, one goes in the top, and they actually talk to each other through direct current, through the bloodstream. The benefit is that once they're in, there are no wires, there's no weakness of the area from the pacemaker box. There's nothing that can be hit to cause them to break. So, for instance, we have other patients who have maybe one in the bottom chamber, one in the top chamber, who are playing football, tackle football, so American football, or playing, wrestling, or doing a lot of activities, volleyball, etc. And they have no issues with that. They can continue to be active, and their pacemakers aren't affected. So we wanted the same for this child who had needed, two different parts to the pacemaker to talk to each other. So needed the top chamber, the bottom chamber to talk all the time. And so that this allows her to play whatever sport she wants.
And so, what were the major challenges that you faced during this procedure? And given as compared to the adults, how risky do you think this procedure was when conducted on a child?
Great question. So, um, you know, we always, I think based on her size and her, she's I think 13 is a great size. Somewhere over 10 years of age, most kids are big enough where at least their neck veins are big enough for these pacemakers to pass through. That's the biggest risk. Leadless pacemakers are designed for adults, so they design them for adult veins to go in through the legs. But given that children's leg veins aren't quite as big as their neck veins, we actually pass it through the neck vein that can be very safe. So thus far, in any of our leadless pacemaker patients we've had through the neck vein or otherwise, their veins have been just fine afterwards. And so that's really the risk. Other than that, we use ultrasound guidance, given that the size of children's hearts are smaller. So we use echocardiogram to look exactly where we're placing the pacemakers at the time. And we do a lot of testing before we deploy the pacemaker, before we release them into the body. And the other benefit too, is these are retrievable. So you can put them in, and once the battery's up in whatever 10, 15 years, we can go back in through the same vein or a different vein and take out the pacemakers and put new ones in. So that's really, I think, the challenge in children is making sure that you know exactly where you're going with ultrasound, not just using X-ray, and then making sure that the vein is sizable enough that you won't cause any damage to it by putting a pacemaker through it.
So, if you could talk about this congenital heart block basically, and how does this affect the quality of life in children? If you could just talk a little bit about that.
Sure. So people that are born with this heart block, some patients are born with it due to either their parents having antibodies from something like from a rheumatologic disease like Sjogren's or lupus, and so these antibodies actually can attack the child's heart. The same thing can happen after myocarditis, actually, after sort of an inflammation from an infection. People can develop this heart block, this disconnect. So over time, once a patient's heart rate is low enough that they're passing out, then they only wake up every two out of every three times they pass out, actually. So patients can die from this, and so it's really important to know that it's there, to keep an eye on it, and to also, prior to heart rates becoming too low, put a pacemaker in place. Now, most kids, if this happens to, once they have a pacemaker, it's lifelong. So then the rest of their life, whether they have it when they're born, whether they have the pacemaker placed when they're 1, 2 years of age, 13 years of age, it's lifelong. And so it really can prevent them from being able to do the same things as other kids. So kids that may be really great at some sport or maybe really want to be just very active have to curb that a little bit in order to be able to have a pacemaker and have it safe and still effective.
So, given the rarity of this instant, basically, were there any alternatives that you thought of at that time before going with the procedure?
Definitely. So we discussed transvenous, so meaning put the wires connecting to a box into the heart, and we also discussed surgical. Now, at 13 years of age, she really didn't want to go through the trauma of having a big open heart surgery in order to have the pacemaker placed. She also we discussed the wires. Once wires are in place from a traditional pacemaker, once those wires break, you have to go ahead and take them out through a procedure called a lead extraction procedure. That procedure has somewhere around a 1% chance of either death or having to surgically cut someone open to be able to remove those wires. So she didn't really want to have to undergo that either. And again, at 13 years of age, if you think about she lives, several decades, she's going to have several replacement wires. And at some point, tear up her veins. At some point, that risk of death or having to cut her open to take those leads out is going to be real. So we really, through all that discussion with the parents, we really sort of then focus on the leadless pacemaker procedure. We also have done leadless pacemakers, like I said, for a while for just single chamber, meaning just one chamber of the heart for some pacing here or there. So she was really the first where we had done two in her age, but we had done this in adults who had congenital heart disease. So people born with holes in their heart, defects in their heart that had surgical repairs where the electricity or the electrical wires were knocked out, during the surgery or subsequently. So we've had a lot of, practice with it, not practice, but we had, basically been doing this safely. It just, she happened to be the youngest patient, and for her, it really made a lot of sense with her desired activity level.
So, did she have any medical history? And if yes, that what what does it mean for patients, like if they have a medical history of some sort?
Great. So for her, it was just the congenital complete heart block. So for her, she was really just followed for a long time medically with a lot of rhythm monitors. So having to wear 48-hour or 2 week long rhythm monitors to keep an eye and make sure her heart rate wasn't going too low, keeping an eye on symptoms. So always worrying about, is she dizzy just because she stood up too fast and was dehydrated, or is she dizzy because her heart rate's actually too low and she could die from being from her heart rate being so low and being dizzy. So kind of keeping an eye on that for a long time. So again, for her, it's this congenital complete heart block, but for other patients who have had surgical procedures, so congenital heart disease represents about 1% of the population. So 1% of kids are born with some heart disease that needs to be, that either holes in the heart, valve issues, things like that. So for those patients who get fixed and then have electrical issues because of that, this could also be a nice benefit for them.
So, what step do you take in terms of the long term safety and effectiveness of this device in a child specifically?
Great question. So a lot of close follow-ups. Every single patient I do a procedure on gets my cell phone number as well. A cell phone, email. They also have the nurse's contact number and a direct lines, so that if anything is funny whatsoever, we get them into clinic right away. They also have now established home monitoring for this. So similar to other pacemakers, now they're establishing home monitoring. So that'll come into play here soon, where actually from home a patient can send what's called a transmission or send a signal where you can actually see what's happening with the pacemaker. But in this case, I do a lot of really close follow up. So we follow them the next day before they leave the hospital, make sure everything's working well. We see them the next week. If everything's still working well, we see them 3 weeks later. If everything's still working well, we do it 2 months later, then 3 months, and we gradually extend it. And then, of course, like I said, making sure they have direct contact. So even if something's funny, even if she's dizzy and vomiting because she's sick, her parents can still call me anytime so that I can always bring them in just to double check. So I think doing a lot of double and triple checks for kids is really important, and a lot of patient education as well as parent education. So here are the things we look out for. Here's how you might know something's off, or if we might need to program the pacemaker a little differently. And so making sure that's established from the get-go and continue to repeat that education is really important.
How is the 13-year child doing at this point of time, sir? Has there been any immediate improvement or observation in it?
So parents noted right afterwards that she stopped having those dizzy spells. She's able to actually do physical activity. She doing gym class at school. Was signing up for the soccer team. Was going to now start moving forward and actually get into athletics, which she had never really done her whole life because again her heart rate was too slow. She would get dizzy doing certain things. So now she can just move forward as though she never had any electrical issue in her heart.
So, are there any plans to share this experience or train other medical teams globally in the similar procedures?
So great question. Actually, so for this kind of leadless pacemaker, again, there are ones that can go in the ventricle in the bottom chamber of the heart, ones that can go in the top chamber of the heart, and then you can do the two where they actually talk to each other, which is what this young lady had. So that is expanding. This is the type of pacemaker is called an AVEIR. It's AVEIR. It's by Abbott, ABBOTT, the company, and they're expanding sort of globally. Like for instance, a few months ago, I was on a call with a physician who implanted the first leadless pacemaker in a ventricle only in a patient in China, for instance. And so it's starting to expand some pacing. And I think once people get comfortable with implanting one device, eventually they'll get more comfortable with the two, with the dual chamber leadless. And we've done a few already in young patients here so far at UC Davis as well. And so I think it will continue to grow. And I think eventually people will, see the benefits of it, and especially the activity level, having people being able to do college level sports, tackle sports, or really physical things, and not limiting a pediatric patient from being able to still be a kid. I think it'll grow slowly but surely, and of course making sure that it's implanted safely, that we all share with each other how to safety precautions, safety follow up, things like that. I think it's going to be really important.
So that brings me to my last question. So there are these two pacemakers that we also use in India. Also aware that, as you mentioned, the one that you've used also here from the Abbott and Micra also. If you could explain a little bit of difference in terms of the effectiveness and the safety, basically, of the both. A little bit of difference, if you can.
So perfect. So the Micra is a time based leadless pacemaker. It's It's really good, I think, for the older patients or for patients who you don't have to worry about removing it. So the 80-year-olds or patients that maybe have a transplanted heart where at some point they'll have to have another transplant, or people with limited lifespan. So for instance, I've used that in children and patients who I knew had limited lifespans, but it was a much, it also is implanted through a vein, so either neck vein or the leg vein. And so that one you can also use, but again, to take it out is really hard. Imagine having fish hooks that hook into the heart and you're trying to get those fish hooks out. There's a lot of risk with that, and actually it's really hard to take out. Retrievable pacemakers like the Avir, they actually coil into the heart and then they can uncoil as well. The benefit of that is that you can put them in, and then retrievability is in the high 90s, especially if you put it in the right spot, meaning sort of lower down in the heart in a nice safe spot. So I think, and then the battery longevity of the Avir is much better. So patients, for instance, who we have just a single device in, who pace less than 40% of the time, on average for kids, we're getting somewhere around 20 years predicted longevity, if not more. So imagine you put it in a 16-year-old, they're 36 by the time they need a replacement. So that's, I think, a big benefit. Again, the micro has its usefulness. Also, the way it paces the ventricle, where it can sense what the top chamber is doing, is through an accelerometer. So it sort of feels motion. And that's okay, but you don't get 100% talking between the top and the bottom chamber. Whereas if you put the two Avirs in, they can talk 100% up to heartbeats of 180, which are more physiologic for a kid. So I do prefer those devices for young patients. Again, doing it safely, making sure you're looking with an ultrasound, make sure everything's really in the right spot and you're not interfering with any of the normal heart function, I think is really important. But again, I think they both have their place.
That brings us to the end of this interview, actually. Thank you so much for speaking to me, Dr. Daniel, and also congratulations on your achievement. And I would also like to tell our audience that this is not the first time that you have set the world record. In 2023, also, you were the first physician in the world to implant a retrievable leadless pacemaker in a child, if I'm not wrong.
Oh,
So,
yeah, no,
what? I'm not wrong, right?
no, you're not wrong. No, but we're this is something that we feel really strongly about doing safely, and again gives kids the ability to do everything they want to do as a kid. So I think the retrievable leadless pacemakers are really going to continue to grow, and we're very fortunate. We have a great team at UC Davis, a good staff that are very supportive and help us. And again, just making sure that we're doing what's safest for the patient is most important. And so far, everything's been very good, and we've been able to have some really active kids with pacemakers.
Thank you so much, sir. Thank you so much for speaking to us.